I'm Caroline Baumel from Tufts Medical Center in Boston. It's a privilege to be here today with my colleagues and my friends, and I'll be presenting on OCT angiography in proliferative diabetic retinopathy. To summarize my take-home points, neovascularization of the retina can be reliably characterized with OCT angiography. Wide field swept source OCTA with depth encoded flow overlay can be used to differentiate IRMA from neovascularization. OCTA can be used to classify IRMA subtypes, and OCTA has potential for non-invasive screening of high-risk diabetic retinopathy as well as diabetic retinopathy severity. Imaging plays a key role in diabetic retinopathy with regards to screening, diagnosis, management, and clinical studies. But I often ask myself, what is the best protocol in my clinical practice? Ideally, this is something fast, safe, accessible, and highly accurate to direct my therapeutic regimens, and this may need one or multiple modalities. This is demonstrating the diabetic retinopathy severity scale, which shows the stepwise progression of diabetic retinopathy. And level 47 and 53 are so important because these signify the steps right before proliferative diabetic retinopathy, where treatment is indicated or there is a high risk of vision loss. One shortcoming to using the standard 7-field image is that peripheral lesions may not be imaged. And this is a patient with predominantly peripheral lesion in diabetic retinopathy consisting of this temporal region of fibrotic neovascularization. OCT angiography with wide field swept source OCTA has potential to image patients with proliferative diabetic retinopathy non-invasively. And here in the right eye of this patient, there's extensive peripheral capillary non-perfusion, an enlarged foveolae vascular zone, and neovascularization emanating from the disc, while in the left eye, there's also very extensive neovascularization elsewhere noted adjacent to the regions of capillary non-perfusion. In this talk, I'll be discussing 3 papers that I was involved with using OCTA for imaging in severe non-proliferative and proliferative diabetic retinopathy. First, I'll be discussing OCTA to distinguish IRMA from retinal neovascularization. IRMA, which stands for intraretinal microvascular abnormalities, is characterized by tortuous intraretinal vascular segments of variable caliber, and it's a key feature of severe non-proliferative diabetic retinopathy. It is the one in the 4-to-1 rule. The presence of IRMA is important because at this point, when there's severe non-proliferative diabetic retinopathy, there's a 50% chance of progression to diabetic retinopathy in 1 year. And there may also be a relationship between IRMA progressing to be retinal neovascularization. Traditionally, fluorescein angiography is performed to characterize IRMA, but there can be some diagnostic uncertainty with fluorescein angiography and overlap with early retinal neovascularization, as in this image where the IRMA shows some subtle leakage. So the purpose of our study was to evaluate the features and characterize IRMA and retinal neovascularization using en-face wide-field OCTA with the co-registered structural OCT with flow overlay and correlate these findings with fluorescein angiography. In this prospective case series, we used the Zeiss Plex Elite 9000 swept source OCTA at 10,060 nanometers. And we used 5 overlapping en-face 12 by 12 millimeter OCTA scans to create a montage such as this. We identified regions of irregular flow and evaluated the flow overlay, which is the sum of the raw decorrelation signals from the OCTA onto the co-registered structural OCT image. We evaluated 9 patients with severe non-proliferative diabetic retinopathy or proliferative diabetic retinopathy and looked at 96 foci of irregular branchings consisting of 70 IRMA lesions and 26 retinal neovascularization lesions based on the fluorescein angiography. IRMA demonstrated intraretinal flow with a core of flow and outpouching of the ILM, but no breach through the ILM as seen here on the flow overlay. There was often areas of capillary non-perfusion noted adjacent to IRMA on the OCTA. So here is a fluorescein angiogram showing subtle flow. What is this lesion? OCTA shows irregular branching, and on the flow overlay, it's seen that this lesion does not extend through the ILM, so this is consistent with IRMA. Retinal neovascularization demonstrated supraretinal flow that breached the ILM and even extended to the posterior hyaloid. There may be intraretinal flow, and there appeared to be a wider core in these lesions. Retinal neovascularization with fibrosis demonstrated less prominent supraretinal flow. There were rare lesions of fluorescein OCTA mismatch, and these were hypothesized due to fibrosis or a transitional phase between IRMA and retinal neovascularization or other sources of retinal neovascularization. In a subsequent study, the morphologic changes in IRMA after anti-VEGF therapy were evaluated with OCT angiography. Initially, the baseline IRMA patterns were characterized, and there were many patterns noted, including dilated trunk, loop, twisted loop, C-fan shape, and net shape IRMA. Subsequent to this, changes were characterized after anti-VEGF therapy, and these were classified as either regression of IRMA, and some of these lesions showed improved non-perfusion, versus progression of IRMA, obliteration of IRMA, or the IRMA remained stable after anti-VEGF injection. In this study with my colleague, Dr. Peachy, we compared ultra-wide field fluorescein angiography and ultra-wide field color fundus photography with the Optos to wide field OCT angiography using the Plex Elite 9000. And again, we evaluated 5 12 by 12 millimeter on-FOS OCTA images as I previously demonstrated. This demonstrates the vitreoretinal interface slab, highlighting neovascularization of the disc and neovascularization elsewhere. It was noted in this study that wide field OCT angiography and ultra-wide field fluorescein angiography had high rates of detection of neovascularization of the disc as well as neovascularization elsewhere, surpassing those of ultra-wide field color fundus photography. And the study concluded that wide field OCTA can identify neovascularization that's not apparent with wide field color fundus photography. It had comparable accuracy between wide field OCTA and ultra-wide field fluorescein angiography, and wide field OCTA is safer than ultra-wide field fluorescein angiography for diagnosis of proliferative diabetic retinopathy. Here's an image that shows a region of neovascularization elsewhere in the yellow box on fluorescein angiography, as well as on the wide field OCT angiography that was not imaged on the ultra-wide field color fundus photography. And you can see on the adjacent OCT images with the flow overlay that there's supraretinal flow. In this image, early neovascularization was not well seen on the ultra-wide field fluorescein angiography, but was well seen on the wide field swept source OCTA as demonstrated in the red box. In conclusion, wide field swept source OCTA may have a role in management of diabetic retinopathy, especially non-proliferative and proliferative retinopathy. The response to anti-VEGF therapy and ischemic indices may play a role in characterizing our therapeutic regimens. And currently, my option to screen is evaluating high-risk patients with a 15 by 15 millimeter and a 6 by 6 millimeter OCTA image using the 200 kilohertz Zeiss Plex Elite swept source OCTA. Thank you for listening, and I hope to see everyone live in person in Rome next year.